Story 1. As a retired X-ray, CT, and MRI technician, my most lasting memory is of a young woman in her 20s who was a victim of a truck crash. She had both feet on the dashboard and was not wearing a seatbelt. The crash shoved her legs into her pelvis, shattering everything: legs and pelvic structures. She survived but spent months in recovery and underwent multiple surgeries. I cringe when I see videos of female passengers with their feet or legs on the dashboard or hanging out of the window. Don't do it. Story 2. I worked as a patient care technician for 4 years. Here's one notable experience. A 600-pound man had not walked or even gotten out of bed in decades. He was in his 60s and had a girlfriend in her 40s who enabled his condition. Due to his weight, his penis had receded into his scrotum, so when he needed to urinate, a staff member had to assist by gently popping it out to get it into the urinal. It was not long enough, and despite assistance, he often urinated on himself, necessitating a bed change. He was so large that he could not sit up to hold the urinal himself, so the staff had to do it for him. He almost never called for help to urinate or for a bedpan. He was continent but chose to soil himself to necessitate a bed change, which he admitted proudly. Bed changes required multiple staff several times a day due to his intentional incontinence. He could not roll over unassisted, so we needed 2 staff members to pull and roll him while one handled the change. A 4th team member assisted with positioning or the change itself. Sometimes he would roll back into the soiled bed because he was too large for us to stop him, requiring a bed bath once he was rolled back over. He did this to watch television, as he could not see the screen when lying on his side. He required a bariatric bed that would not accommodate regular sheets, causing us to run out of bed sheets frequently due to his constant bed changes. He was admitted for difficulty breathing, and it was discovered he had several areas of severe cellulitis on his lower extremities with open wounds that needed dressing changes multiple times a day, also requiring multiple staff for assistance since he could not lift his legs. He displayed extremely inappropriate behavior towards female staff, leering and making comments if his girlfriend was not present. She practically lived in the room, so he kept most of his comments to himself. However, whenever he had to do anything other than lie there, she would scream that we were torturing him and grab at staff who were helping him roll or reposition his body. We often had to ask her to leave the room during bed changes, and he would moan and wail in a way that made her rush in to save him. He was on a strict diet due to his weight and diabetes, but she constantly brought him fast food in excessive amounts and yelled at anyone who looked at the bags. After every bed change, she would lay in bed with him, stroking his face and telling him how wonderful he was, criticizing how we treated him, and calling him brave and strong, all while staff were still present in the room. He was over 600 pounds, unable to move in bed without assistance, emitting a strong odor, and covered in skin infections that worsened because he failed to communicate his need for a bedpan. He was disrespectful to staff, and his girlfriend sabotaged any attempts by his medical team to help him by bringing him forbidden food. This led to frequent incidents of him soiling himself, causing his waste to enter his open wounds and exacerbate the infections, resulting in a constant mess that required our attention. We spent so much time with him that it hindered our ability to care for other patients. I provide all this detail to convey what follows. The most shocking incident I witnessed was walking into the room and finding his completely naked girlfriend trying to mount him. Since he could not use his penis without assistance, I was unsure what she expected to achieve. She was overweight but not to his extent and still somewhat independent, needing to move furniture to climb onto the bed. She dislodged his cardiac monitor, which prompted my visit, as the telemetry station indicated he had flatlined. She was angry that I interrupted their moment and that I had to touch her man to adjust the monitor. He simply stared at me in silence. She yelled at me when I attempted to shut the door for their privacy on my way out, accusing me of sabotaging his care. My family often asks why I didn't pursue nursing school, and I cannot imagine subjecting myself to individuals who neglect their own well-being and mistreat those who care for them. Story 3. The patient was suffering from metastatic bone cancer that had spread to multiple organs. He weighed around 80 pounds. He received fentanyl for pain management, which caused his blood pressure to drop. The family became anxious and decided to withhold all pain medications, including Tylenol. The patient was still classified as full code. Ethics were involved in the situation, and the family was not well received on the unit. He passed away experiencing significant discomfort, and he did not deserve that fate. Story 4. Every time a patient has a living will or do not resuscitate order, is very ill or at the end of life, they should be allowed to pass peacefully. However, some family members may reverse the DNR, which forces a 98-year-old grandmother with metastases to be treated as a full code. It is unacceptable and should not be permitted. Story 5. Cardiopulmonary resuscitation-induced consciousness. One of my patients coded during my first night shift as a nursing assistant. I was called in to perform compressions, which can be distressing. You can feel ribs break, the rib cage flexes in ways that can be nauseating to witness, and the entire situation is honestly quite violent. However, what was truly horrifying, compared to the numerous other codes I had experienced over almost 8 years, was that this man was awake. I was pushing against the bed frame while he attempted to stop me. Compressions are extremely painful, and he was grabbing at my wrists to push me away, maintaining frantic eye contact. But if we stopped compressions, life faded from his eyes like a candle flame, so we had to keep going. A few minutes later, they administered a sedative and paralytic for intubation, which stopped the struggle. We tried for nearly an hour, but we couldn't bring him back. Even a decade later, I still clearly remember the look of pain and panic in that man's eyes as he stared up at me during the final moments of his life. Story 6. I remember working a shift in the pediatric department, and it was busy just like every day. I remember putting my head down and registering children and their families as quickly as I could. Meanwhile, in the sea of crying babies and distraught parents, I noticed one mother holding her 4 to 5-year-old in her arms. She was in shock and must have come in during the rush to find an empty seat. She was cradling her limp child, who appeared unconscious, with a look I will never forget. She looked hollow. That's the best way I would describe it. I interrupted the current family in front of me and waved her over to talk to me. She managed to blurt out that her child had accidentally been run over by a car in reverse, and she began wailing and pleading to save her child's life. We called for emergency assistance and rushed the child into a trauma bed. I'm not a nurse, so I wasn't part of the life-saving measures, but I remember feeling glad I managed to spot her in the busy waiting room. Sadly, I don't know the outcome of what happened to her child because the shift ended up being chaotic, and by the time I was off, I just wanted to run to my car. It's been over 7 years since that experience, and I will never forget the state of shock and the look on that mother's face. I also think it's safe to say every healthcare worker remembers the first patient they ever saw die. Mine was a large, intoxicated man who was kicked out of a downtown bar. He fell and hit his head on the concrete and was immediately unresponsive. We received a call that active cardiopulmonary resuscitation was being performed and that the patient should go straight to the trauma bay. I remember I was working one of my first night shifts and ran the paperwork to the trauma bay. I stood near the social worker at the back of the room to stay out of the way. Not much time had passed when the doctor called the time of death, and I remember being stunned. That's it? This is what they talk about in all those emergency room shows? Was there nothing else they could do? I walked back to my desk and told the people training me that he had passed. I remember how unfazed my coworkers were while all I could think about was how fragile life is. That person, who I assume went out for a few drinks, definitely did not predict that they would get kicked out of a bar, let alone die a few hours later. I lost sleep and cried a lot over the situation. I'm now over 12 years working in the emergency department, and I have seen many lives pass through. I am always humbled by how amazing our staff is, and how unique and fragile all lives are. It's tough work, but I feel privileged every day at work to be part of any patient's health journey, even if all I do is gather their information and give them wristbands. Story 7. Not the worst, but unique. An industrial accident caused by unknown factors, likely poor maintenance and minimal attention to safety, resulted in a wire under tension on a spool rapidly unspooling and then snapping. Several people suffered horrific lacerating injuries, including amputations and near-total scalping in one case. There were severe brain injuries, and one individual suffered a length of stiffened, heavy gauge wire penetrating the eye and exiting through the back of the neck. They were alive when brought in but died from a post-operative infection weeks later. They were blinded, semi-conscious at times, but unable to speak the whole time following the incident. Story 8. I don't see much in person since I am a medical laboratory scientist and spend most of my work time in the lab. However, there was a time I had to bring a cooler with emergency uncross-matched red blood cells to the trauma room in the emergency room for a patient who was coding. The curtains were closed, so I couldn't see what I was walking into. I pulled back the curtain to find the coding patient spread eagle on the bed with several workers around them. I expected that, but I did not expect the patient to be covered with multiple sores filled with maggots. The sight was bad, but the smell was the worst thing I have ever encountered in my life. The patient's family members were wailing in the corner. Apparently, the patient was mentally handicapped and had been suffering horrendous neglect and abuse wherever they were living. I couldn't retrieve my cooler for several hours after the patient passed away because the police closed the room as evidence. Story 9. A new mother left the postpartum ward against medical advice and subsequently died at home 24 hours later. The attending physician urged her to stay admitted because she had a bad feeling about her going home. Although the numbers appeared fine on paper, the patient did not look well and had an underlying chronic condition. The doctor repeatedly remarked that she looked as though something bad was going to happen. Unfortunately, his intuition proved correct. I can't explain it, but something felt off. It was a terrible incident, and the entire obstetrics department was shaken for a while afterward. Still haunts me. Trust your intuition, everyone. Another experience occurred when I was a nurse in the emergency department. I was assigned 11 patients at the start of my shift due to call-outs and was told that if I did not accept the assignment, it would be considered my resignation. It disturbed me because the day before I had been laughing with my managers, and then they were threatening me the next day. It is strange how quickly people can change. Story 10. More ventilators than I had seen collectively up until that point were all supporting near-death patients in a cramped makeshift intensive care unit early on during the COVID-19 pandemic. I was doing my fellowship and was in hospitals in the middle of Manhattan every day. Much of the COVID-19 experience was surreal and awful. Freezer trucks filled with deceased bodies, codes called every 20 minutes, normally. There would be a code called less than once a week. And the bizarre experience of families thanking me and other doctors for putting ourselves in harm's way even while their loved ones were dying alone. I could only cry on the phone with them because there was little else to do. The image of all those ventilators was horrific. It represented chaos, uncertainty, and fear that reached all the way to the top. There were no experienced individuals to turn to for advice. It was so new that no one had answers or solutions or even a way to ensure people were not suffering. We were on message boards discussing strategies that had been successful for doctors around the world because we had no literature to draw from. Knowing those machines were all that stood between patients and death. Knowing that usually that room was a recovery area meant for 6 to 8 postoperative patients, but which now held probably 25 patients, none of whom were postoperative because the operating rooms had essentially been shut down. And knowing there were dozens more people boarding in the emergency room waiting for someone to die so a ventilator would become available was overwhelming and terrifying. The people attached to the ventilators were scared and uncomfortable but couldn't see or touch their relatives unless they were actively dying. And by that point, they were not cognizant of their surroundings. This experience changed something deep inside me very permanently. The period I'm discussing was actually shorter than I perceive it to have been. It wasn't long before azithromycin was identified as helpful for lung infections, followed by remdesivir and discovering laboratory tests that could help predict severe disease to prioritize treatment for those patients. It was surreal knowing that the patients attached to those machines, many of whom died, were literal sources of the useful knowledge that led to the development of vaccines and antiviral treatments. Those weeks spent in the hospital, knowing more patients were coming in need of our help, while we genuinely didn't know what to offer them, and realizing that some people would be beyond our ability to help, was demoralizing and traumatizing. I still have not returned to the same doctor I was before the pandemic. Story 11. I had a 30-year-old woman who had just accepted a teaching job. She was excited but developed a headache, which turned out to be an aneurysm. She was doing well until she suddenly couldn't breathe. I told her it would be okay, that her mother would be by later, and that I wouldn't let anything bad happen to her. We needed to sedate her to help her breathe. She died 5 days later. She was so heavy that I cannot even tell you how much she weighed due to all the fluids and medications we had her on. She didn't look like the same person. I had 12 pumps running at a time for medications and electrolytes. But despite our efforts, she died. I was the last person she looked at and the last one she talked to. I told her I would take care of her. I can still hear her mother screaming. It still traumatizes me today. She was my first patient I had on my own, with my preceptor by my side, who had 20 years of experience. There was nothing we could do. It was a tragedy. I can still see her face. Story 12. My friend and coworker saw a post from our surgery residence account showing them performing microsurgery in the cadaver lab on a decapitated head. It was her grandfather. She knew he had donated himself to science after death. She just wasn't expecting that. Him, at our hospital, our cadaver lab, our specialty. Story 13. I work in an HIV clinic, not a hospital, and I am a pharmacist. We don't usually see severe cases, but I used to work the evening shift when the sexual health clinic was open. We primarily treated sexually transmitted infections, but we would also provide post-exposure prophylaxis for HIV. This was over a decade ago when access to post-exposure prophylaxis was limited. One night, a young woman was brought to us from the hospital after being sexually assaulted by multiple men. The last one told her he had HIV. I had to explain how to use the medication and what to expect. The look on her face was unlike anything I had ever seen, totally blank and void. She seemed unable to speak or respond, and her hands were bloodied and swollen. I will never forget it. I still think of her often and hope she is okay. Story 14. Pediatric emergency department worker here. An attempted murder of a 5-month-old infant occurred. The infant's throat was slit laterally with a piece of glass. The perpetrators were the infant's mother and maternal grandfather. Story 15. I was observing a surgery when the fellow performing the procedure walked in and started bragging about how he had only slept 2 hours in the past 2 days. Story 16. A man came in with chest pain. It turned out he had been rationing his insulin to pay rent. That was the most disturbing part. Not his vital signs, but the system that forced him to choose between breathing and having a home. Story 17. As a student, one of the radiographers tested us by showing unusual cases to see if we could spot the pathology. He showed me a hand X-ray, and it was a perfect, beautiful textbook image. I examined it for a good 10 minutes before he took pity on me and pointed out that there was nothing wrong with the hand other than it had been cleanly detached from the arm. A machete wielded with force can very cleanly sever an arm. Story 18. Child abuse and sexual assault patients can be difficult to discuss. I recently encountered a case where the little girl resembled my own daughter, which affected me deeply for days. I struggled to comprehend how someone could harm their own child. Story 19. When I had my first child, I lost a lot of blood. I have a bleeding disorder that many have never heard of. Basically, I was dying from a slow postpartum hemorrhage, and the doctor was not going to be bothered to do anything. On the 3rd day after giving birth, my hemoglobin was 5.2. I couldn't even stand without losing consciousness. I looked like a literal corpse with grayish skin and yellow under my eyes, and my mucous membranes were almost white. I overheard a neonatal intensive care unit nurse say to another nurse, "She's not going to live to see tomorrow if they don't do something now." I spoke to my postpartum nurse, and she was terrified for me because every time she brought it up with the obstetrician, he brushed it off. It took my husband yelling at the doctor to get someone else to check me and provide the transfusion I desperately needed. For units later, I started to perk up. That's my personal story. I was an emergency nurse, so there are many more experiences I could share. Story 21. An elderly woman whose husband had attempted to amputate her gangrenous toes with garden shears. Horrific abuse suffered by an 18-month-old girl. An elderly woman who had been too unwell to leave her sofa for a week. A woman with unexplained E. coli bacteremia and suspected Munchausen syndrome introducing toilet water into her 4-line. Story 21. A young woman became unresponsive at home. She was severely obese, requiring the fire department to cut through the house to assist her. When a urinary catheter was being inserted, maggots were present. It was a very sad situation. She was 40 weeks pregnant at the time, and I decided to start my maternity leave after the catheter was placed. Story 22. I am a nurse, but this story takes place outside the hospital. Home health visits I conducted 5 days a week for months for a patient in a hoarding situation. The house had bug infestations, animal feces on the floor, rotting food, and recurring maggots in the patient's wounds. I cannot get the smell of the house out of my nose, and it has been years since I experienced it. I disinfected my shoes after every visit to remove the animal feces. It broke my heart. The family refused any outside help from social services and were fully competent, so there was nothing I, adult services, or the medical team could do. However, I made several attempts to assist. I had many heartfelt conversations with them about the potential negative effects their home environment could have on the patient's health, but I was never successful in helping them beyond my nursing duties. I cared for the whole family very deeply. Story 23. This was disturbing to me as a child in the 8th grade. I was a candy striper at a small local hospital and loved it so much that I worked the whole summer. There was an elderly woman who would constantly scream for help, and the nurses just ignored her. I finally asked why someone was not going in, and they said she was fine. She just wanted a cigarette. They told me I could go in and help her smoke, so that is what I did about half of the time I was there. Her family never came to see her. At the end of the summer, she was so happy and said her family was coming to take her home on Monday. I was thrilled for her. I mentioned this to a nurse and she said no, they aren't. They are sending her to a nursing home. There was zero compassion in her voice, and it broke my heart. When I went back, she was gone, and I worried for years about her. I still think about her, and I am now 65. Story 24. I had a patient with untreated skin cancer due to mental illness. The cancer affected his head, and he would come in for pain management and then leave. His skull was missing above his eye, making it look as if someone had sliced away his face. By his last admission, he came in with maggots in his wound, which was so large that his eye was deflating and he was leaking fluid. You could see his brain pulsing. It had eroded through his skull and the protective layer surrounding the brain. Interestingly, it used to smell of rotting flesh, but once the maggots arrived, they consumed the dead tissue, and the odor diminished. He refused to let us remove the maggots, but they eventually died off. He was on comfort care, and there was a significant ethics meeting because he was very restless and at high risk of falling. If he fell, there was no protection for his brain, and we were not willing to restrain him. Instead, we would respond quickly when he triggered the bed alarm. We tried having a caregiver with him, but he eventually passed away peacefully. I was relieved for him because there are some conditions worse than death, and that was one of them. Story 25. I am a nurse. I had a patient with a tracheostomy whom we recently weaned off the ventilator because they were doing better. They still needed their trach for airway management and also required some oxygen. They were improving, so another nurse and I got them up from bed and sitting in their chair. It was Easter and they wanted to call their spouse. The patient couldn't talk because of their trach, but they heard their spouse on the phone, who kept saying, "I love you. I am so happy you are doing better." My patient had the biggest, most genuine smile. I left them in the chair to check on another patient. Less than 10 minutes later, I ran back to the room because their monitor was alarming, and I saw my patient slumped over in the chair with blood flowing out of their trach. I had never seen so much blood. With my adrenaline pumping, another nurse and I lifted them back to bed, and I immediately started compressions without even putting on protective gear. I was soaked in blood. They did not survive, and to this day, I have no idea what actually happened. Story 26. Short staffing and how we are not supposed to say anything about it. That is being dishonest. I would be upset if I were lied to like that. Story 27. The damage was horrific. It was not my patient, but a friend's. Story 28. A social worker in an acute unit observes the disturbing lengths to which people will go when experiencing withdrawal. They have witnessed individuals consume hand sanitizer for its alcohol content and drink their urine in hopes of finding remnants of narcotic medication. Story 29. I am a medical imaging and radiotherapy student on internship. A patient had cancer on the skin of her lower leg. We had to administer radiotherapy treatments in segments. One segment that had previously been treated appeared to be deteriorating. It emitted a terrible odor and looked extremely unhealthy. I think it was decaying, but I didn't ask because I honestly didn't want to know. The worst part was that after being in a locked room for 20 minutes, when we came to get her out, a fly flew away from her wounds. I believe she brought it inside with her because there were no flies there before. That's how severely it was decaying. Story 30. Once, while in school, I observed a nurse who did not wash or clean her hands even once during an 8-hour shift. I was disgusted. Story 31. Family members gathered around the bed, discussing who would receive what and arguing about which lawyers to hire, while the patient, who was dying of cancer, was still alive. Senior doctors were stealing opioids but, despite being caught, managed to keep their jobs without even facing suspension. One patient, who had not been diagnosed but was showing symptoms of dementia, repeatedly asked for another spoon, which he was using inappropriately. An elderly woman in her 70s attempted to use drugs after surgery, having brought a small kit containing a tourniquet, spoon, syringe, and needle. Story 32. I work with a nurse on a pediatric oncology ward who exhibits troubling behavior. She often upsets the children and taunts them. I have reported her multiple times, but no one has taken action. She has shown racist tendencies, particularly towards black children. I am one of the few who confronts her actions and brings attention to her behavior. I'm surprised I still have my job there because we clash frequently. Story 33. GF is a psychiatric nurse. Recently, she had a patient who removed their own testicle using only their fingernails. I am slowly becoming desensitized to her normal dinner conversations since she moved in. Story 34. A patient had been restrained to their bed for over a decade. His actions leading to this were terrifying. He lost a limb that was placed in a bin and disappeared, forcing him to search the morgue for it. Walking into an organ harvesting operating room felt like entering a butchery. Entering the intensive care unit during COVID-19 and seeing all the patients on ventilators was overwhelming. The labor and delivery ward was filled with distressing sounds. I assisted in bagging a deceased body, and the person with me slapped a label on the face of the body. It was very sad. A patient died during my first emergency code, and I had a strong feeling that they were watching me. Story 35. My mom worked in medical transcription 40 years ago and told us about a man with gangrene who had his penis break off and float in the therapy tub. Story 36. Not so much disturbing, but one night while sitting alone in the staff room of an operating theater, where I used to decontaminate and clean after operations, I had an unsettling experience. I had heard stories about strange occurrences but had never seen anything myself. That night, as I was walking up the corridor, the hallway light switched off. There were no timers or anything. It felt as if someone turned it off, yet no one was around. Then I felt a coldness, and someone whispered, "Go," in my ear. I ran out of there so fast. The next day, I spoke to others about it, and I found I wasn't the only one to experience that. Story 37. Not a worker, but I was in the hospital with a prisoner. We were in the emergency room and were transferred to an actual room. We passed a homeless man with an open leg wound. I have smelled 3-day-old brains, and it could not compare to the smell from that man. It smelled like feces, body odor, and decay. The nurses were even commenting on how bad it was. Story 38. This isn't really gruesome, but rather saddening and insightful. I process medical records. I was part of the team that scanned paper medical charts into the medical record system. We organized all the paperwork in chronological order and kept track of the visit ID number on each patient label to ensure we did not mix up 2 different visits for the same patient. Some psychiatric patients were in the hospital for a very long time, sometimes exceeding 12 months. Some patients would injure themselves or had other internal medical issues. There were many cases where I would assemble patient restraint flow sheets spanning months, with each flow sheet tracking 24-hour periods. Some patients would spend months in the psychiatric inpatient unit before being transferred for a few weeks to the internal medicine inpatient unit, and then back to the psychiatric unit. One individual I remember had about a dozen of these transfers, mostly due to sepsis and skin damage, preventing proper healing. I also encountered a brochure for a halfway home, presented like a children's storybook. The patient was an 18-year-old with developmental disabilities, a large individual with diminished intellectual capacity. They were admitted at age 17 on a 72-hour hold due to a physical outburst at home. No one felt safe taking custody of them after the 72-hour hold, leaving them with no place to go. Following that initial 3-day hold, they lived in the hospital. The local school district sent a small bus to take them to school each day and brought them back. After turning 18, the hospital discharged them to a halfway home. We are a regular inpatient hospital, not a long-term care facility. Even pre-pandemic, 20% of our nation's inpatient beds were occupied by individuals needing long-term care. There are not enough long-term care beds available for patients without financial resources, nor for patients with medical and psychiatric needs, or medical and addiction issues. Story 39. If someone has a do not resuscitate order and something seems off about the patient, they shrug their shoulders and say, they are a do not resuscitate. When it is someone over the age of 90 and very fragile, but their family is still receiving benefits from them, and the family keeps them as a full code. We have to be okay with it. Story 40. I'm in the lab, so I only see containers of blood and urine. We have received urine samples from babies twice, and although they had a lot of volume indicating dilution, they still resembled Pepsi in appearance. Story 41. Elder abuse cases where the elderly individual weighs 89 pounds and is covered in stage 4 bed sores, but is kept on full medical support because she's a fighter. In most cases, the family that keeps her alive lives in her house and collects her social security checks on her behalf. Story 42. Severe anorexia. She went so far as to drink a caustic substance that fused her esophagus shut and was refusing her feeding tube. She appeared emaciated, with the outline of every bone visible. I have witnessed many traumatic injuries, including gunshot wounds, open fractures, and a man whose entire thigh was severely damaged by the tranquilizer he continued to inject. Perhaps because this woman wasn't particularly graphic, she was haunting. Story 43. A rectovaginal fistula was severely infected. The patient kept inserting muffins and food into the area. The smell was unimaginable. Story 44. During an observational practicum, I witnessed a family struggling to accept that their grandfather, who was over 90 years old, was dying. They insisted on having a feeding tube inserted into his stomach. Unfortunately, he was unable to receive most forms of anesthesia, so the procedure was performed with minimal anesthesia. Although he could not communicate verbally, the sounds of his pain were overwhelming. I vowed never to let such a situation happen to me. Story 45. People allow their parents or loved ones to live because they are too selfish to let them die comfortably. Story 46. Healthcare workers often discuss patients insensitively. Having a mental illness can impact how one is treated for physical ailments. Human life can seem undervalued in hospitals, and workers can be cruel to patients in pain, who simply seek decency and respect, even in their final moments. Some individuals derive joy from causing harm to patients or their colleagues. I hope to never work in a hospital again. I was traumatized. Story 47. I was a psychiatric charge nurse for a year. My hospital had 2 psychiatric units, and I was usually in charge of one unit but would cover another if they didn't have a charge nurse. One day at 9:55 a.m., I heard over the intercom, "Code Blue, Room 214, Code Blue Room 215. I rushed to the other psychiatric unit. I saw the crash cart in the room. The patient was pale, with blotched skin, blood pooling on the backs of his arms, and his hand resting on his head. When I moved his hand, his whole arm was stiff. I still had to try to resuscitate him before the doctor arrived. I began chest compressions. I am 6 feet 4 inches tall and weigh 270 pounds. His chest felt like pressing on a solid board. He was already in advanced rigor mortis. The emergency response team showed up and took over. I went to grab a sturdier gurney for transfer if needed. The code lasted 3 minutes until the doctor finally arrived and called it. A few questions I will answer before they are asked. The patient was a full code, so any life-saving measures that can be taken need to be taken until a doctor declares time of death. We worked on a psychiatric unit, and any patient death is an immediate state investigation because patients are supposed to be medically clear before admission, and this patient had already been on the unit for a week. In most hospitals, the doctor or house supervisor will notify the family. The charge nurse responsible for this floor was in a full-on panic, so I had to handle the phone calls to the sheriff, organ donation, and the family. The code itself was distressing, but having to notify the next of kin broke me. There is a cry called keening, an uncontrolled wailing that happens when someone is in immense distress. It triggered me immediately into a psychotic state. That night, as I drove home, all I could hear were the screams of this patient's family, and for a year, I saw the grotesque visage of the dead patient sitting in the back seat of my car out of the corner of my eye. For 6 months, I experienced panic attacks as I relived the events while driving home from work. I would start to feel anxiety, then he would appear in the rearview mirror, and the screaming would build. A few times, I had to pull over in a parking lot, park under a light, and get out of the car to catch my breath. For 3 weeks after the event, I had to sleep with a nightlight because I saw him in the shadows, and the screams never quite went away. Finally, after a year, everything was minimized, but when I started working in the emergency department on night shift and someone passed away, the memories came flooding back. I made a therapy appointment the following week and was shocked that after only a few sessions, I was able to put that experience behind me. No more flashbacks or hallucinations. 8 months since therapy, where I worked through so much else, I am in a much better place. During my orientation in the emergency department, I watched a neurosurgeon drill a hole in a man's skull and insert an intraventricular catheter to monitor a patient's intracranial pressure. Oddly, after seeing that, I almost passed out when the anesthesiologist pulled out the needle to perform an epidural on my wife when she was giving birth to my son. While I was a psychiatric charge nurse, I helped with code blues throughout the entire hospital. One was called on the telemetry floor on the 4th floor. I rushed upstairs and assisted in running the code. We worked on her for 20 minutes, but her heart just would not start. She still had some brain function from us circulating blood with chest compressions. When the doctor said, "I am about to call time of death. Does anybody have any objections?" The patient still showed agonal breathing, but had an unfixed gaze and uneven pupils. I later learned from the patient's cardiologist that up until that morning, she had been a do not resuscitate case, but hours before she expired, the family had rescinded the order. Story 48. Night shift and random doors opening and closing with no one around, or equipment randomly beeping and making noises despite no issues with the equipment. Essentially, just haunted hospital hallways. Story 49. Previously, I worked as a hospital social worker. I loved the work but actively tried to avoid gruesome images and documentation in the chart. Sometimes it was unavoidable when I was conducting chart reviews to look for recommendations at the bottom of a note, as these often contained images. One day on my caseload, there were multiple patients about to transfer to hospice and one patient with adult protective services involved, an older male. The older male was bedbound, and his wife had not been providing proper wound care due to religious beliefs. The bed sores had progressed to the point where his bones were visible. I was aware of this from the documentation and the involvement of adult protective services, but I was actively avoiding the images. I almost made it through the entire day, but seeing the images broke me. It was the only time at that job that I ever cried, and those images haunted me for months. Story 50, X-ray and CT technician here. I received an order for a tibia-fibula X-ray for a leg wound. I went to the patient's emergency room to perform the X-ray, and the nurse mentioned it was perfect timing as they were about to remove the wrap from his leg. When the wrap came off, there were maggots everywhere. That was a first for me. I have encountered this a few more times since, and it never gets any less disgusting. I would prefer to deal with blood, gangrene, or basically anything else. Story 51. Pretty mild, but when I was working on the gastrointestinal ward, we had an elderly gentleman who had just received a new stoma formation. Everything was going well, but the patient's wife said they had lost his dentures and was blaming us. We searched thoroughly and found that the patient had swallowed his partial denture. An X-ray confirmed it was currently in the small bowel, and preparation for surgery began. Our expressions changed when the healthcare support worker screamed and ran out of the room while changing his stoma. We rushed in and saw teeth poking out of his belly. There was no need for another surgery. Story 52. I'm not clinical, but I'm allowed to wear scrubs of a certain color if I don't have meetings. During COVID's peak, the number of people who vocally threatened me in public, tried to hit me in a parking lot, or followed me home was overwhelming. I'm just an ordinary person, and I can't imagine how female staff were treated. I know we started requiring people to go in pairs or groups to the parking garage for a while to go home. It was awful. Story 53. The worst thing I have experienced in 11 years of nursing is the amount of tax taken off my payslip after working weekends and nights. Here is an actual patient-related story. I worked in the intensive care unit for a while. We had a patient code, so it required all hands on deck for that situation. Afterward, when I returned to my patient, they were acutely confused, had a nasogastric tube and a stoma. I returned to their room to find them consuming the contents of their stoma bag because they were thirsty. The sound of suctioning liquid from a stoma bag out of someone's mouth will haunt me for the rest of my life. Story 54. One of the main things I wish people in the medical field understood is that those outside your job do not know what these abbreviations mean. This is what your comment looks like to the rest of us. I had a patient who came in with a non-life-threatening cardiac event. We took 3,000 blood counts and compiled them into a heart rate limit, but what we didn't realize is that the heart failure index was in over maximum, so we had to calibrate with 400 liters of workflow per day. That ended up doing the trick. Story 55. Just as some other staff talk to patients, it is important to remember that many individuals may not be cognitively intact, yet they still deserve dignity. Staff may raise their voices, ignore them, or insist that a patient cannot do something they are actually capable of doing. Story 56. Children who have been sexually abused. Children who have been murdered. Kids dying in accidents. Fallen firefighters. Miscarried twins. Miscarried single babies. Kids with cancer. That is a truly difficult question to pose to someone in healthcare. Story 57. A patient resembling the main character from The Exorcist is forcefully vomiting green bile across their bed. Story 58. Everything reveals the best and worst of humanity playing out simultaneously, like a dramatic television series inside one giant building. It is all completely real, and you are trying to finish your shift, get paid, and save enough energy for the next day, which is the same thing all over again. Story 59. Former paramedic, now physician assistant. I responded to a house around midnight where a man in his 20s was sitting on the driveway. He had severe injuries. His calf was hanging by a small piece of skin, and he had deep cuts from his shoulder blades to his lower back. His skin was shredded and hanging. He appeared detached, sitting in the driveway with a police officer beside him, as if he were on a beach. He stated that his father-in-law inflicted the injuries during an argument. While assessing the injuries, the officer mentioned that he had some cuts on his back as well. Upon inspection, I confirmed that he had been severely injured, likely with a box cutter or a similar object. He was unsure of the weapon used. Both he and his father-in-law were heavily intoxicated. I did not enter the house. Instead, I secured him and transported him to the trauma center. The violence is what always impacts me, what one person can do to another. Story 60. Not all hospital staff are free from issues, as some doctors misuse drugs, smoke, and struggle with alcoholism while advising their patients against such behaviors. Story 61. I worked as a nurse on a psychiatric ward. Occasionally, I took some patients out for errands in my own car. We would go shopping for cigarettes or clothing. I always assessed whether it was safe to take a patient with me. I believed it was important to treat them equally and normally, so they felt comfortable and safe. One day, I went for cigarettes with a 60-year-old man with schizophrenia. His condition was relatively stable, and his psychosis was never harmful to others. On the way back, as I was making one of the last turns toward the ward while driving at 30 kilometers per hour, he suddenly opened the car door and attempted to step out. The open door slammed into a road sign. I immediately stopped the car, and he got out and walked away. While this walking away was acceptable since he was free to do so, it may not have been the best moment for him to leave. Story 62. The individuals are affected by what they see. I would like to see fewer of these questions and more humorous and positive moments for them. Story 63. I believe that everyone at the bedside has a story that is very similar to this one, although my own experiences with similar patients did not include the unusual girlfriend. Story 64. Gunshot wound victim shot in the mouth. Arrived as a scoop and run by police. Surprisingly, the victim was walking but left a trail of teeth behind. Story 65. My mom works in a palliative ward. The things she tells me are really scary. I don't know how she can handle it. Story 66. I had only worked in healthcare for a couple of years when I met a patient who was being evaluated for breast cancer. She had refused medical treatment for so long due to religious reasons, and the cancer had progressed significantly, resulting in a large, foul-smelling open lesion on her breast. I doubt she survived very long after I met her, but I never forgot the smell associated with cancer. For years afterward, I could tell if a patient had advanced cancer just by the odor on their breath, especially in the case of lung cancer. Story 67. A patient ignored a lesion on his face that progressed to necrotic metastatic skin cancer, ultimately consuming much of his facial tissue and forming a large tumor. Such a tragic situation. Story 68. I work in the office, so I usually don't come across anything traumatic or disturbing. I was in the hallway going to my office when an older gentleman collapsed in the busy lobby. Luckily, a few people helped him and called for assistance right away. I wasn't trained to make overhead announcements and didn't know how to help. I hope he is okay. Thanks a bunch for sticking around till the end of the video. Remember to subscribe, and until next time, stay awesome and goodbye.